Thank you. Thank you very much. Thank you, Binay, and my sincere apologies for not being there. It's not often that you have two speakers from two similar sounding but distinctly different wonderful universities. I am from Washington University School of Medicine, and my good friend Renato Martins is from University of Washington School of Medicine. And today, I'm sure you will have a very comprehensive overview of what's happening in the field of lung cancer. These are my disclosures. And I want to discuss the update in lung cancer in under four different sections. We'll begin with immune checkpoint inhibitors, then we'll discuss the targeted therapies, and then I want to briefly mention a few important studies in locally advanced non-small cell lung cancer that are maturing or that are ongoing. And finally, I want to say a few words about the ongoing work on genomics and lung cancer. And as you can imagine, over the past several years, the approach to non-small cell lung cancer has changed dramatically with the advent of immune checkpoint inhibitors. And the CT scans like this are the main reason for this. And this was very novel, unusual several years ago. It's a commonplace now. And as you can see here, a patient who has had KRAS mutant lung cancer, had multiple lines of therapy, has had a spectacular response here with the nivolumab. And these were absolutely remarkable then, remarkable now, of course, for the patients, and it's become a commonplace in clinical practice. Before we delve into the data regarding immune checkpoint inhibitors in lung cancer, I just want to briefly go over a few things on the basics of cancer and the immune system so that you can understand how these immune checkpoint inhibitors work. As you can imagine, a normal cell, when it gets transformed, has abnormal DNA molecules that result in abnormal proteins that invite the attention of the immune system. In the ideal world, these transformed cells would be so abnormal that the immune system would find it sufficiently foreign to eliminate this. And in such instances, the patients will never develop cancer, will not even know that a few cancer cells were floating around in the blood circulation. Unfortunately, that is not often the case. And for various reasons, the cancer cells avoid immune system's attention, and they strike a harmonious equilibrium for a number of years in many cancers, and perhaps for a number of months in some cancers, and they live in harmony. At some point, these cancer cells really escape immune's attention, and by doing a few things, one of them, of course, is deletion of the molecules that present the antigens to the immune system. Deletion of the HLA molecules is something we have seen repeatedly in lung cancer in genomic studies. Or more commonly, these tumor cells express inhibitory molecules, and one group of molecules are the PD-1, PD-L1 axis members. And of course, CTLA4 and others play an important role in various cancers as well. And clearly, going after the PD-L1 is an attempt to move this cancer from the way of escaping to set an equilibrium, put it back in the equilibrium stage, and eventually, at some point, with some diligent combination, eliminate the tumor completely and even achieve a cure, if possible, in a setting of non-small cell lung cancer in the metastatic disease stage. Today, we have 3 drugs that are approved with regard to immune checkpoint inhibitors and lung cancer: nivolumab, tislelizumab, and pembrolizumab. And as you know, nivolumab and pembrolizumab are PD-1 inhibitors, and tislelizumab is a PD-L1 inhibitor. As you can see here, the schedule of administration varies a little bit, nivolumab being given every 2 weeks, pembrolizumab and tislelizumab every 3 weeks. And I just will review the key phase 3 studies to bring you up to date. And by now, I'm sure you know very well the results of the Checkmate 17 and Checkmate 57 studies from the nivolumab trials. They had similar design. These are patients with previously treated non-small cell lung cancer with platinum-based agent. The 17 trial had squamous cell non-small cell lung cancer. The 57 had non-squamous non-small cell lung cancer. And patients were randomized to nivolumab or docetaxel. The primary endpoint is overall survival. And as you can see here, big difference in survival with a hazard ratio of 0.59 for the squamous trial, with a near doubling of 1 year overall survival. Similar results, perhaps numerically less impressive, but nonetheless clinically and statistically significant, were seen with adenocarcinoma with the 57 trial. Again, significant improvement in overall survival with nivolumab compared to docetaxel. And in fact, the more updated results show that these benefits are not transient. And in fact, if you can see here, the duration of responses with nivolumab exceeds 2 years in squamous cell lung cancer, a little less than 2 years in non-squamous non-small cell lung cancer, significantly different than a few months we are used to seeing regularly with docetaxel. Not only that, the results are pretty impressive. When the responses happen, they're fairly deep and they're sustained. As I just mentioned a few minutes ago, these are the well-known spider plots. And even though nivolumab is approved, regardless of PD-L1 expression, you can see the trend here with literally no PD-L1 expression. You see mostly stable or progression, whereas with PD-L1 expression, you can see significant decreases that are sometimes quite long-lasting. And that, of course, started off the field in lung cancer with the use of immune checkpoint inhibitors. And then very soon others caught up. And these are the important studies that we'll be discussing in the next few minutes with other agents. The first one of this is pembrolizumab Keynote 010 study, which included patients with both squamous and non-squamous non-small cell lung cancer. Again, in the second-line setting, looked at two different dose schedules and two different doses. And these are the curves you see with 50% or above or more than 1%. Again, significant differences in outcomes seen more impressively in the 50% and above PD-L1 expression. And tezepelumab, the first PD-L1 inhibitor approved for the treatment of non-small cell lung cancer. Again, similar design comparing docetaxel in the study called OAK study, showing differences in survival favoring tezepelumab, almost similar magnitude here. And that led to the approval of tezepelumab in the second-line setting of non-small cell lung cancer, regardless of PD-L1 expression. And whether you look at the intent to treat population or the immune-enriched population, the results were seen, and that explains the approval in the all-comers group. So with 3 drugs, with solid, well-designed clinical trials showing superiority over docetaxel, there is no question that in second-line setting, regardless of PD-L1 expression, nivolumab and tezepelumab are appropriate agents in the second-line setting. In the meantime, as we were working on the appropriate agents for second-line immune therapy drugs, pembrolizumab moved up very quickly to the front line, chiefly because of this study, which is a 024 Keynote study, where patients with newly diagnosed non-small cell lung cancer were randomized to get platinum-based doublet or pembrolizumab. One important entry criterion for the study is PD-L1 positivity by the 22C3 antibody, 50% or more in the tumor cells. This study included patients with both squamous and non-squamous non-small cell lung cancer with a primary endpoint of progression-free survival. As you can see here in the graph on the side, there was a huge difference in this group. Pembrolizumab was vastly superior compared to chemotherapy with an impressive hazard ratio of 0.50. The response rates were nearly double with pembrolizumab, and that is absolutely quite remarkable. And again, showed an improvement in overall survival as well. And this favored, again, pembrolizumab with a hazard ratio of 0.60. So this really changed the field in the frontline setting. Now the PD-L1 expression testing has become standard, and if it is positive, one could make a case for pembrolizumab based on the Keynote 04 trial. And of course, things got even more complicated a year ago when these results were published. This is not a randomized phase 3 study. I want to underscore that this is a randomized phase 2 study where patients with metastatic non-small cell lung cancer, this time not squamous, non-squamous non-small cell lung cancer, were randomized to get chemotherapy with pemetrexed and carboplatin, or chemotherapy with pembrolizumab, pemetrexed, carboplatin, and pembrolizumab in the frontline setting, which showed a greater response rate with a triple therapy combination compared to the doublet combination, and that resulted in improvement in progression-free survival by nearly 4 months. And overall survival data are immature at this point, but the combination therapy resulted in an increase in response rate, increase in progression-free survival in this population, regardless of the PD-L1 expression, 50% or more. And that led to the surprising approval from the FDA of this combination based on phase 2 data. And so technically, if you believe in this data, and ready to use this. This is approved by the FDA. And again, this has changed the way we approach frontline non-small cell lung cancer. To confirm these responses from this small randomized phase 2 study, phase 3 studies are ongoing, and hopefully we'll get confirmation not only with pembrolizumab and chemotherapy, but with other agents as well. And as we move on beyond a single agent checkpoint inhibitor with chemotherapy, now it has become very common to study combination of immune therapy drugs in both in the front line and in second line and beyond in non-small cell lung cancer and other cancers. I want to briefly show you the results of the nivolumab ipilimumab combination, the Checkmate 012 study, this is a large phase 1 study with a combination where nivolumab is given 3 milligram per kg body weight every 2 weeks, along with pembrolizumab given either every 6 weeks. Ipilimumab given every 6 weeks or 12 weeks, showing really increase in response rates. And you can see that response rate increase is seen regardless of the PD-L1 expression here, favoring the combination more compared to nivolumab alone. And of course, the combination therapy produces more toxicities, and that's something worth keeping in mind. So these are not standard lines of therapy at the moment, and these are being investigated. Various other combinations are ongoing at the present time. I would not use these combinations outside the context of a clinical trial, but just want to show you that this is an actively a moving field. And I just want to spend a few minutes to talk about the side effects of immune checkpoint inhibitors. I want to put this in perspective here. If you look at the results from the nivolumab, tezepelumab studies in the second-line setting and compare them with docetaxel in combination with ramucirumab and nintedanib, what kind of side effects you see, it's a bit of an unfair comparison for many reasons. These are different trials, and the docetaxel studies pointed here have a combination agents here. But the point here is that the side effects from the immune therapy in the second-line setting are fairly reasonable, well-tolerated. Severe side effects leading to death are extremely uncommon with immunotherapy drugs, contrary to the early fears. And the adverse events leading to discontinuation are in single digits with immunotherapy drug combination. So that's important to keep in mind. There is a significant point to keep in mind. Unlike the traditional chemotherapy or even targeted therapy-related side effects, immune-related side effects are in a completely different ballpark, and they can affect any organ, obviously. And because of that, we have to now suddenly become good top-line internists or have wonderful colleagues who can help us to manage various side effects. The simple rule is any organ can get inflamed. And the common ones are, of course, problems that we see with colon, skin rash, lung inflammation, liver inflammation, or occasionally arthralgia and arthritis. Although there have been reports of encephalitis, cardiac issues, as well as nephritis with these agents. So it is important to keep an open outlook here, and if one should be very, very careful to pick up these complications. Of course, hypothyroidism is seen routinely, fairly commonly, I should say, and it is routine to check the TSH levels every few months or so when patients are on checkpoint inhibitors. A few pointers in terms of side effects. I just want to spend a few minutes on pneumonitis. And pneumonitis is incidence of significant pneumonitis is in the 5% range. And there is no particular group that is at high risk, to the best of my knowledge, for pneumonitis with checkpoint inhibitors. And these checkpoint inhibitors themselves, in my opinion, are identical in terms of incidence, severity, and predisposition to pneumonitis. We do not see, based on the data I've reviewed, less incidence of pneumonitis with PD-L1 inhibitors or PD-1 inhibitors. They cause identical rates of pneumonitis. For mild asymptomatic changes, you can continue therapy with close monitoring. And if they're mild to moderate, it's, I think, important to hold therapy and try a course of steroids. And severe symptoms, of course, you have to hospitalize them, administer IV methylprednisone after making sure that there are no infections, and ideally we recommend the bronchoscopy, evaluation, biopsy, cultures, etc., and a proper workup. And if it is deemed to be radiation pneumonitis related to immune checkpoint inhibitors, it is important to withdraw steroids over time and not immediately upon seeing some improvement. If necessary, we will use infliximab and other agents to tamp down the inflammation. And when patients have significant pneumonitis, grade 3 or 4, and you do not restart them, grade 2, grade 1, of course, you can restart them, but you have to carefully monitor them. There are various forms of pneumonitis that have been reported in the literature. This is one form that you see here, and there have been wonderful reviews published. I would refer you to those reviews. And it's important to really recognize them fairly early on. The basic theme is the same thing for other serious toxicities like colitis, hepatitis, or arthritis. I would just make a few points that when patients have significant colitis, infliximab has been shown to be fairly helpful. And for hepatitis, mycophenolate mofetil, I personally used it with some great effect, especially steroid-sparing effect. And it's important to be very careful in restarting these agents. Of course, an interesting question is, do patients do well if they have toxicities, immune therapy-related toxicities? And it turns out that the patients who have immune therapy-related toxicities seem to do a little bit better compared to those they don't have in studies in melanoma. And as we have more and more data, we probably will have a much better handle on this issue. The other tricky point is that what do you do with the patient who has psoriatic arthritis or rheumatoid arthritis, who have a life-threatening lung cancer, who have limited options? And of course, we have become increasingly bolder here, and we have treated a few patients off protocol. We carefully monitored them and optimize their therapies and use them without provoking significant inflammation. But it is an area that we don't have much data. You have to be very careful about. And there have been a few papers published on this topic. And here, once again, from melanoma and ipilimumab. And there is a prospective trial that's being planned to enroll patients with well-controlled rheumatoid arthritis and psoriatic arthritis and lung cancer with immune checkpoint inhibitors through the Alliance Cooperative Group and monitor them carefully. And those studies will give us a lot more confidence and a lot more useful data regarding the use of these drugs in patients with pre-existing autoimmune disease. And I just want you to be careful when you use them, and they were not included in those registration trials we discussed earlier on. I would not go too much into detail as Dr. Martins will be discussing the biomarkers. I just want to point out there are various biomarkers and they have different sensitivities. The IASLC conducted a comparative group. Most biomarkers were comparable. The SP142 did not do so well in terms of comparison, but then most of them looked fairly identical, as you can see here. I would leave the biomarker discussion to Dr. Martins. And so moving on to the next topic with targeted therapies, I just want to highlight a few important studies that were presented at the recent meetings. One is the Archer study, which randomized patients with EGFR mutant non-small cell lung cancer to decometinib or gefitinib with a primary endpoint of progression-free survival. This is, to the best of my knowledge, the first randomized phase 3 study comparing the first with a second-generation inhibitor. And as you can see here, the primary endpoint was progression-free survival. And this study met the primary endpoint and clearly with decometinib superior to gefitinib in terms of median progression-free survival. At 2-year point, nearly 3 times the number of patients were without progression with decometinib compared to gefitinib. And the response rates were identical, but the duration of response was significantly better with decometinib. And the overall survival data are fairly mature. Of course, the natural question is, how does it stack up with afatinib? This is a slide I borrowed from my colleague, Karen Kelly, and showing here the Lux Lung 7 data, comparing gefitinib with afatinib, nearly identical median progression-free survival here numerically, and with a hazard ratio in favor of afatinib. And this was a randomized phase 2 study in comparison to the Archer study. And you can see those specific characteristics. Decometinib and afatinib have significantly more toxicities compared to gefitinib. And this is, in reality, one more option for our patients with EGFR mutant lung cancer in the frontline setting. Of course, the big question is how will osimertinib do in comparison with erlotinib or gefitinib, and those studies, the first-line use of osimertinib, those results will be available fairly soon, and those studies have been completed. And if that study turns out to be positive, then the significance of the Archer study may become less certain. But certainly, there are more options for our patients. And then moving on to the ALK-positive lung cancer, this is an important study, the ALEX study, comparing alectinib with crizotinib in ALK-positive non-small cell lung cancer in the treatment-naive setting. And the primary endpoint is progression-free survival. There was a significant improvement in progression-free survival with a median PFS of 11 months with crizotinib, similar to what has been reported before. And the median progression-free survival has not been reached with alectinib, with a hazard ratio of 0.47, whether it's investigator-initiated or independent review, the results were significant. And if you look at the independent review assessment, and you can see that alectinib median progression-free survival was nearly 2.5 times longer compared to crizotinib. And more impressively, the effect on brain metastasis was quite striking. And patients with measurable CNS metastasis, the outcomes were significantly better. Of course, this was preserved in those without CNS metastasis as well. And the time to CNS progression was strikingly different between crizotinib and alectinib. And as you can see here, is quite remarkable at a year point after the patient with crizotinib had CNS progression. With alectinib, it's about 10%. And this is truly a wonderful activity of alectinib in the brain mets setting. The side effects are very tolerable. There are no major side effects of any great concern. And so for somebody who has used alectinib for a long time on clinical trials over the last several years, I would say this is an extremely well-tolerated drug with no significant weaknesses with regard to toxicities. And what is notable is that the results from the ALEX study are very similar to the J-ALEX study conducted in Japan, published last year. And the doses are a little bit different here, but then the results are identical, with a median progression-free survival not reached in the alectinib trial at the time of the initial presentation, with crizotinib right around 10 months. And so these are really, these two data, two large phase 2 studies, granted done in different population, clearly showing that, and this is an active drug in the frontline setting. So the standard of care has changed in the frontline setting. ALK-positive lung cancer, alectinib is a new standard. Moving on in the last couple of minutes, in the early stage non-small cell lung cancer, unfortunately, and locally advanced non-small cell lung cancer, we have not made as much progress. We have not made any progress at all in locally advanced non-small cell lung cancer over the past 15 years. These are two large trials, one looking at the high dose versus conventional dose radiation, randomized phase 3 study conducted by RTOG, and this is the PROCLAIM study comparing pemetrexed cis with etoposide cis, both showing no advantage to new therapies. In this context, the results of PACIFIC study that will be released formally soon are very significant. This is PACIFIC is a randomized phase 3 study where patients with locally advanced non-small cell lung cancer got chemoradiation and then got randomized to durvalumab, a PD-L1 inhibitor, or placebo. And the primary endpoint was progression-free survival. And we learned a couple of months ago that durvalumab significantly reduces the risk of disease worsening in the phase 3 PACIFIC study, and the results are expected very soon at the upcoming ESMO meeting. And if that results, the results are as impressive as the press report makes it sound, that would change the standard of care in locally advanced non-small cell lung cancer, perhaps for the first time in 15 years. And then in terms of targeted therapies, it is not standard to give EGFR mutant or ALK-positive non-small cell lung cancer with respective kinase inhibitors. This is an ongoing study. Full disclosure, I'm the principal investigator of this study, one of the principal investigators, and the study is accruing rather slowly. So my personal plea to all of you is that if you have the study open, please consider enrolling patients for this important study. We do not treat off-protocol patients with EGFR mutant or ALK-positive lung cancer with TKIs. Similar story with EGFR mutant non-small cell lung cancer. It is not standard to give erlotinib or crizotinib or any of those kinase inhibitors in these patients because they have not been proven to be superior. Number of studies are currently ongoing. The biggest one is an Alchemist study where patients with non-small cell lung cancer are randomized to, are screened first, and they screen for EGFR or ALK rearrangement. If they're positive, they get offered to participate in the study randomizing patients to erlotinib or observation, crizotinib or observation, or now nivolumab has been added or observation. Most recently, we made some changes. Placebo has been taken off, so patients who are not getting the active therapy don't need to come to the office every 6 weeks. And this study is picking up momentum, open in 200 sites, got about 2,000 patients in the screening arm. We got about 128 patients. We're about a third of the way in, and we need more help from people like you. Once again, I'm one of the investigators in the interest of full disclosures. And finally, the genomics of non-small cell lung cancer. Compared to what we knew 10 years ago, now we have known extensively in terms of research, genomic analysis, data from genomic analysis of 1,500 patients with non-small cell lung cancer. We have known now that adenocarcinoma is a disease of the RTK RAS pathway alterations, and we see a lot of heterogeneity. And this heterogeneity is seen in all cancers, more so in lung cancer, where you have a founder mutation and you have various branching points and how the tumors evolve rapidly. And that information can be used to prognosticate. And this is an important paper. I would refer you to read this paper in the New England Journal of Medicine, published a couple of months ago from Charlie Swanton group, showing that subclonal copy number alterations can predict outcomes in patients with non-small cell lung cancer resected, and with a hazard ratio of about 5, those with a high subclonal copy number alterations showing a highly genomically complex tumors. More importantly, in a related companion paper published in Nature the same week, and they showed that they can track it down in the blood. And here is a curve that's showing that the greater tumor volume is associated with the greater number of cell-free DNA in the blood. And more importantly, you can predict the changes in the clinical relapses that you can see here. And months before the clinical relapses happen, the cell-free DNA count increases in number. If we can confirm these results, potentially we may screen them very differently in the next several years compared to doing them with CT scans alone. In the US, we are doing a large study looking at 3,000 patients with lung adenocarcinoma, looking at genomic alterations at a very deep level to fully understand how these cancer cells evolve. In the last couple of slides, I want to show you that in the coming years, we will have multiple combination studies in immunotherapy. Here is the list of activating receptors and inhibitory receptors. There are drugs for literally all of them, and those combination studies are currently ongoing in various forms, in various institutions, in various countries. And more excitingly, we are now entering the era of adaptive T-cell therapy and personalized vaccine therapy. And here is an example where a patient's tumor is harvested, and a whole exome, whole transcriptome analysis is done. We use computer models to predict the new antigens and then come up with the vaccines that we give it to patients and go after the specific mutated genes, and that we can develop customized vaccine therapy and in order to kill these cancer cells. So with all these things, I think immunotherapy will play a major role, not just use of checkpoint inhibitors, but many other forms. And in summary, I want to end by saying that for EGFR mutant non-small cell lung cancer, the update is we have a new drug that is called dacometinib in the frontline setting. In the ALK-positive non-small cell lung cancer, alectinib is clearly the frontline choice. And now we have salvage drugs. Brigatinib was approved recently. Very soon, hopefully, we'll have lorlatinib and other drug called ensatinib in the salvage setting for these patients. And if patients have EGFR wild type, ALK cross negative, and the PD-L expression is over 50%, pembrolizumab is the appropriate choice. You could also argue that regardless of PD-L1 expression in those triple wild type patients, you can give pembrolizumab, pemetrexed, and carboplatin. After all, it's an FDA-approved regimen. And in the second-line therapy, if patients have not got immune checkpoint inhibitors, it's definitely an important option, regardless of regardless of PD-L1 expressions. For those who got checkpoint inhibitors, platinum doublet may be an option, and that is an option, although it has not been tested formally. And docetaxel will always be an option without ramucirumab. I'm hoping that PACIFIC results would be encouraging enough that we can change the practice and advance the field of, or the treatment of locally advanced non-small cell lung cancer. I would plead with you to consider enrolling your patients for both ongoing locally advanced as well as early stage non-small cell lung cancer with targeted therapies. Thank you very much.